Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Jake McCarley, CEO and co-founder at Alluvium. Jake, welcome to the show.
Thanks for having me.
So, Jake, what I always like to do at the beginning of every show is to give my guests more of a chance to provide an introduction in terms of who they are and what they do. So, Jake, the floor is yours.
Yeah, thanks. We've been serving the healthcare market for around 9 years. I started the company along with my co-founders 9 years ago, which is crazy to think. It goes by faster than you. It's like long days, fast years. I guess it's the same with like having children or something. But so we jumped into the healthcare market 9 years ago, looking to solve for patient access and helping specifically at the time with referral patterns and helping with leakage and helping patients get access to care. And that's kind of evolved, over the years. And I serve as a CEO of the company and have since the founding. And so it's been a wild ride.
So what got you into healthcare to tackle that as the industry that you wanted to go to?
Yeah, great question. When we started, it wasn't really, hey, there's this burning desire to want to solve for referral leakage and patient patterns, right? It wasn't, that wasn't necessarily the motivating factor. I worked for a big corporation, and I knew that I was kind of an entrepreneur at heart. I knew it was what I wanted to do from a vocational standpoint. And so we were looking at actually a couple of different problem sets. And I think what drew us to healthcare was just the humanness of it. That there's problems in every industry, but there was just something about, as I interacted with leaders as we were kind of testing out our original thesis, there's just something human about the healthcare space. And people wake up every morning and fight through a lot of really difficult things just to be able to provide care for the people in their community. And I liked that aspect of healthcare, that it was still a very community-oriented, a very human-centric industry, and there's just you've been in healthcare for a long time yourself, so there's no shortage of opportunity areas to work on, and so I think that combination of just unlimited problems to solve, and there's still many left, unfortunately, and just how people relate to their work in the space has just been really compelling to us.
Yeah, no, I think picking up on that ability to really drive interactions among people and have a direct impact on people is, I hear that so often when I ask people why they got into healthcare. And it's, I think, as you said, no matter kind of which piece of the industry you're working in, it always comes down to that potential impact or that actual impact, and be able to see that change and, hopefully make it a slightly better place as a starting point really drives a lot of passion working within the industry.
Yeah, I think that's right. I mean, that's even how we think about it. Often, people will kind of focus on the patient aspect of it, and there's certainly things that we do that directly impact a patient's experience. But when we look at the work that we're doing, we primarily see those frontline caregivers and those office managers as the people who are delivering that touch point. And so we take a lot of pride in being able to help them remove all of those barriers to them being able to serve those patients with the care that they deserve and the care that they want to do. I think that's what's so compelling about healthcare workers is like, I don't know that I've ever met a single one who wasn't. They just want to take care of that patient. They just want to make it easier for them to get access to care. And so if there's things that we can do from a technology standpoint or a workflow standpoint that can free them up to do that, that's where we play, and they get the joy of delivering that firsthand for the patients. So we're just in the background,
Yeah. So when you're looking at enabling folks to deliver the care that they want to be able to give and driving access, kind of going back to as you said when you were starting the company, like patient access wasn't necessarily the first thing on your mind that you thought you were going to get into. So how did you end up in that area, and what does access mean to you?
Yeah, it's a good question. I think that's changed over time. When we got into it, we were actually trying to solve a different problem. Actually, we were thinking that we would build a Priceline-like platform to solve for pricing transparency, and that was one of the originating ideas, because I'd had this personal experience of needing to provide for care for my family, and I was on a high deductible health plan, which, as you know, you're 100% responsible for your care. And as we experienced that, there were just no tools available to be able to know what to pay for something. Yet I was fully responsible for it. And so we kind of take this Priceline like platform in and pitch it to a group of providers. And they kind of laughed us out of the room. They're like, "Hey, I appreciate that you want to be able to show pricing as part of a search experience, but as a provider, I don't even know what I'm going to get paid. So it's almost impossible to do that." But that workflow thing that you were solving, I actually cannot move a patient from my setting to your setting without faxing something or without handing that patient a piece of paper and saying, "Hey, here's 3 cardiologists that we think would work for you. Good luck picking which one and calling that office," and things like that. And so we actually stumbled into landing on solving for referrals because I was actually naive in the fact that I didn't know that still happened. I thought, man, honestly at the time, I just scheduled an appointment with the person who does my haircut over a text message, and they're still faxing forms to try to move a patient. And so I was, that's the best way to start a company is with some naivety, because you're crazy enough to go after it. And so we decided to focus on, okay, well, how do we make it possible for you to go in and see a provider and for them to schedule with that next step in your care process immediately before you leave that office? And so when we started, Access was really centered on referral management and being able to solve that. And as time went on, health systems, we work with very large health systems, some of the biggest in the country, and once we solve for how do we make the referral process better, the next iteration is, well, how do we make it easier for a patient to self-schedule? And so then Access from our viewpoint then started to become, well, not only how does the staff do it, but how does the patient self-schedule, like through a website? So if you go to healthsystem.org and you want to search and schedule, find a provider, how do you make that process work? And so we expanded Access to really view 2 different demand channels, if you want to view it like that. And then over time, it's really what we came to learn is, in a health system, revenue cycle is very disciplined. Every health system we've ever gone into, very disciplined revenue cycle. It has a clear leader. Everything is organized and it's ran like a discipline. It's ran like a system. And what we started to realize from an Access standpoint is Access, not only is it the front end of rev cycle, because you can't collect payment on a patient who hasn't been there. So Access is key to rev cycle, but it's actually not ran like a system. It's not ran like a single unified discipline. And so we even started to look at who was asking us to help them solve their problems. And there were some on the demand side. There were some on the, let's call it the supply side, the leaders who are responsible for organizing the provider directory and organizing the capacity of the health system and how do you make that capacity available, et cetera. And so this vision started to unfold as we kind of played that with health system leaders. Like, what if we were to elevate Access to the level of discipline that revenue cycle has and to view it as one cohesive system? The things that you have to offer and the ways and the demand channels by which patients are trying to get access to that care, what if we treated that like a unified system? And so that's kind of our new product lines have really elevated Access to be this cross-functional supply and demand oriented view to help leaders have actionable intelligence on what to do within Access. That's kind of our new, and I don't think I would have started there when we started. Now I would argue I wish I would have started there and then built out referral and consumer. But hey, that's kind of how it goes when you're building.
Yeah, and kind of picking up on the point that you said of, you had to bring the discipline to that Access component. And, after coming to the realization or the observation really that it's, kind of that one of the first steps to the revenue cycle management, what were some of the challenges and lessons that you learned as you worked to help your customers, develop that discipline around what you described as was a, previously kind of Wild West kind of approach, it sounded like.
Yeah, it's going to sound overly simplistic, but I think quieting the noise for them and simplifying it into something that they could actually see has been the most impactful things. The leaders that we're generally serving, COO, CFO, chief digital officer, chief marketing officer. Like these leaders have enormous pressures. They have 10 different things that are coming at them, both from a reimbursement side that changes the financial elements that they're trying to manage, and then they have the insane amount of noise from the AI industry and the equal challenge of trying to prevent everybody from throwing it into Chat GPT and solving the problem internally and messing up a whole bunch of stuff. And so we do not when we go in and have these conversations, it's really like from an advisor standpoint of helping them cut through the noise and to be able to see access as a unified system, and then honestly holding no judgment in that and saying like, yeah, if you step back and you say, well, yeah, obviously we should manage our access system like that, right? I mean, I don't think that's a counterintuitive thing to say, right? So, but being able to help them get to that point and actually do something about it is how we've navigated. I mean, the number one thing that I hear, it's the exact phrase over and over again, which is, you know what, I never thought about it like that. And it's not because these leaders aren't intelligent. These are some of the best leaders in the country that work in the healthcare space. It's just that they've had so many other pressures. It's really hard to step back and see the forest through the trees kind of a scenario. And if we can provide the intelligence layer that allows them to have that view of access, then we can start to, you can almost hear them breathe out when they're able to see that, right? You can feel their heart rate slow down where they're like, I can actually understand what this is. And now I can start to organize what I want to do about it versus just taking swings at it.
Right. It sounds like there's a large component to just being able to vocalize it and hone the conversation or the focus in on those points, because as you said, it's really easy on a day-to-day basis to get swamped by whatever crisis or whatever issue is popping up that day, and have that overtake your ability to really, as you said, take that step back and look at the bigger picture, because you're on that day-to-day basis. No one's giving you that opportunity.
Yeah, exactly. And I mean, I experienced this. I'm sure you do. I feel anxious or I feel overwhelmed when I can't make sense of it in my head. And once I have it organized in my head, and I can, regardless of how big the problem is or the amount of work that I need to go do to solve that problem, if I can lay it out in a very clear to understand, this is reality, then I can start to work the problem. And then regardless of how big it is, I can actually step into taking the first step towards solving that problem. And then that's what we see with these leaders. It's just, hey, we're going to remove all of that angst and give you visibility into access and help you take the next 2 or 3 steps. And we're going to do that in alignment with your goals is how we've approached it.
And when you're looking at kind of aligning those goals, what are some of those first couple steps that you commonly see taken? Because I do suspect, there are differences among every system or group that you work with, because it's, they'll all take it slightly differently. But as I said, I imagine there's got to be some kind of common threads that you see pop up more often than not.
Yeah, we see there's a lot of variability in the why or where they want to end up as a result of that. I mean, whether you're for-profit or nonprofit health system, no profit, no mission. So it's not that nonprofits don't care as much about the financial incentives, and it's also not true that for-profits care less about the patient outcome. That's not true. I think each kind of have a different angle, and they end up boiling down to really being able to understand what capacity I actually have, and if I want to go run a play, or I want to drive 1,000 knee cases, total knee replacements next year, then how would I even model how I would do that? And what we see in access is generally things are very reactive. You generally have visibility into the things that happened, and they're generally months old in terms of what would happen. And those are instructive, and you need to understand what happened. But if you want to make real-time decisions, you actually need to be able to understand what the capacity is, what is the capacity of the orthopedic service line in Dallas, Texas, and if I were to run X, Y, and Z play, then what is going to happen in that market in orthopedics? What's going to happen? And what do I need to go do to steer the boat there? Or if I'm a marketing leader, I want to spend $500,000 on targeted ads. And if I just blindly go out and say, well, I want to do that in orthopedics because it's a higher value service line, But yet I'm not aware that the capacity within orthopedics is so low, there's no chance of scheduling those patients, then the objectives get misaligned. And I think that's where we're seeing the most value with the leaders we're helping is giving them actual citable data from within their existing environment that we run through models that allow them to forecast what's going to happen within their access, supply and demand, equation, if you want to call it that, that allows them to pinpoint things to change that would then free up more capacity or realign labor to a different market based on what's going to happen. So I think that's where we see the alignment happening, regardless of what and why on the financial metrics. It has to do with capacity.
Yeah, no, kind of those lessons are really important. And for those of you just joining, I'm talking with Jake McCarley from Alluvium, and we've been talking a lot about access. And Jake, kind of at the end of that last answer, you were starting to switch into talking about the capacity, and it sounded like capacity of what the existing clinicians and ability to deliver care looks like, which it sounds like is maybe kind of an overlooked area, because it's like so often you hear the discussion of how do we get the patients in? How do we find the patients who need these services? But you were making the point that you could find all the patients you want, but if they can't get in for a visit, or the clinical team doesn't have the ability to expand the number of visits or otherwise treat them, you're still going to be stuck in the same place. So, looking at the clinician capacity side of it, kind of what are some of the lessons that you've seen or helped, others learn as you've gone through being able to develop better forecasting capability?
Yeah, that's a long journey. Being able to figure out how to do forecasting. Historically, it's been a very long journey. I think some of the new tool sets that are available that we've leveraged to build our newer models allow you to speed up that journey. And historically, when people were trying to solve for capacity, the first thing that they'll do is they'll try to standardize their templates. So they'll go in and they'll say, well, Matt and Susan, they have different templates, and they have different templates that's not optimal. And so when we take those and we put them into a search and schedule on our website, or we make them available to the call center, it's inefficient because everyone is on different templates. And the theory is if we can solve for templates, then we can run a more efficient operation. And that's not untrue. And you do see improvements from running templates. You also see, though, a degradation in the system, because what you're trying to solve for with templates is the ability of the technology to actually run the model you're trying to do. So when you're solving for templates, it's actually more a limitation of the technology that you're using, as much as it is, hey, we think that this will be a more efficient workflow in the practice. And I'll give you an example. So if you go in and you say, hey, I'm going to do 2 new patient slots in the morning and 2 existing patient slots right after that, that's a good thing to do, because providers, there's a lot of reasons why a provider may want it that way. The challenge comes when you're not able to fill it in that exact order from a demand standpoint. And so you start to have and we've seen this where patients have implemented certain EHRs, or they've implemented certain templating strategies where their overall capacity actually goes down when they implement templating, because they weren't aware that once you do that, it adds inefficiency into the system by not being able to fill patients in that exact order of the way that your templates are laid out on the schedule. So there's all these different dynamics that with the modern tool sets and things that we're able to do is you're able to solve for the physician's schedule and the physician's preferences and being able to do that. But you need to be able to dynamically move those templates around based on how the demand channels are coming in and what's available. You don't want to pass on a patient because it doesn't fit the right template model. You want to be able to adjust those templates in real time based on the demand that you have. That aligns then with your strategy. And so that's what I mean by like elevating access to thinking about it more as a system versus as solving for specific workflows within that system is really helping leaders with being able to increase their capacity as it relates to access versus decrease it.
Yeah, it really sounds like the boiled down message is don't create too many restraints by wanting to focus so much on a template, because if you do that, you're looking at it just really in black and white. Whereas, I think as you were describing, there's a lot of nuance and a lot of gray in there that requires maybe a little bit of shifting here and there based off the experience. And it's, really working to mesh both what the clinicians want in terms of what their schedule could look like, but also then matching it with the patients, and kind of over time being able to learn from both of those perspectives.
Yeah, exactly. And so maybe the simple way to say it is historically people will solve for the ability to use technology by going the template route, because a lot of the older technology can't handle non-standardized templates. But that created the inability to manage it dynamically. And then now you can actually do both. Like our models are such that you can control the environment and make it standard, but you can also dynamically adjust that environment while honoring the physician's desires and wishes and scheduling rules and things like that, to be able to maximize the ability to put patients in there. And honestly, that's if physician organizations could increase their capacity 5 to 10%, it would almost eradicate the perceived shortage just within the existing platform. That's what's exciting to us, is like there's this perception that, and it is true, like we are going to have likely going to have a physician shortage, but how much of the physician shortage is related to our inability to run the existing system well versus the end result of our physicians are too busy and now can't see any more patients. And we believe there's probably some left in helping our existing physicians operate better that would free up some capacity to take the pressure off of it being a shortage, if that makes sense.
Yeah, no, and I think that's kind of a key point that you're making there, which is that it's kind of maybe some of those built-in inefficiencies by having too narrow of a focus make it kind of undercut the ability to work optimally or the most efficiently, because as you said, if you can't fill a particular visit just because that's how they want to, you're looking at it in a one dimension. But if you expand and look at a couple different variables at the same time, if you make some adjustments but staying generally within the parameters, all of a sudden you're going to see that maybe you're not having as much of an access issue as you thought you were. It was more of a misalignment of desires and needs on both sides. But if you can kind of move the puzzle pieces around a little bit, you're going to have you'll get more matches. Even if I think, as you're recognizing, it's not going to 100% solve the problem, but if you can narrow that problem down, that's a pretty significant impact.
It's a pretty significant impact. And once you're able to do that, then we're able to see that you're actually able to extend that idea, that systems level thinking, as it relates to even long-term business planning. So I was with a COO of a health system this morning, and the problem set we're helping them with is like they have the way that they do physician recruitment, and this is normal across most health systems, is that they will collect effectively business plans from each of their units, whatever that may look like, or hospital or physician group, et cetera. They'll aggregate those over time to see what the growth potential for those are going to be by market. And then they aggregate the need, and then they take the best swing that they can on what that existing capacity is. And then after a bunch of modeling, they're able to derive, I think I need 35 physicians as part of our recruitment plan in these specific specialties. That process takes dozens and dozens of people across 3, 4, 5 months, and they do that on an annual cycle. So that's like how they do physician recruitment. And so if you're able to manage access from a system level standpoint, you're able to actually set that up as just inherent in the system to be able to monitor your long-term plans, and you're able to keep those things in sync, and you're able to actually derive through our models the ability to derive physician recruitment in real time at any point that you want. So an executive can just go in, and we call it the sandbox. The executive can go in and say, hey, what if I wanted to get 6% growth and I wanted to skew that towards orthopedics over cardiology or gastro or whatever, and I want to do that in San Antonio next year, what are the types of things that I would need to do, and what's my physician recruitment? The model will run that in real time, and you don't have to call dozens and dozens of people in and get to a static answer. You can actually do that in real time in a dynamic way. And I think that's where we're encouraging leaders to think about this as a dynamic system that you can manage in real time versus a fragmented system that has static answers that you then have to refresh every year.
Yeah, and I think as you're also saying, like if you can do that more real time, you can get out ahead of the issue more quickly. And especially using the example of recruitment, I think most systems know that is not a short process. Like it takes time not only just to locate a potential hire, but you have to go through the negotiating process and the onboarding process. So it can easily be 4 plus months, even once you've identified the person before they actually start. So, the more efficiently you can manage that process, it's just going to, I think, as you were saying, improve the business plan because you get to execute on it more quickly.
Yeah, that's exactly right. And it's been fun to see, different leaders how when you kind of open this up and you say, hey, here's the realm of possibility. Here's what you could do. It's fun to see what they come up with. And honestly, the most human answers that I've heard, which I just love because this is like real life. It's not what you would see in a boardroom or whatever. Like this is like a real leader, how they're thinking. The two that I found most interesting in the last couple of weeks that I've heard multiple times there. One is just, hey, what do I got to, and you can interact with the platform via natural language. So you can actually just interact with it, very similar to how you might have interacted with ChatGPT or Claude or something like that. You can directly ask our platform, what do I specifically need to do to hit my personal goals? Which is not something people feel really comfortable asking in a broader environment, right? And I thought that was just the most honest. It's like, hey, I have personal goals. I want to hit those. I want to contribute to the health system. Help me understand how I can hit that as it relates to access is one of them. And the second is, hey, I had this crazy idea on the drive in from work today, but I'm a little embarrassed to ask my BI team about it. Like it's a little off the wall, and it's probably not right, or and that's why we think of it in terms of an executive sandbox, because it's not. There's no judgment. It's like, hey, throw your crazy idea out into the platform, and let's see what we can model, and maybe it is a direction changing idea for the health system, but they're hesitant to do that when they have to bring in multiple teams to be able to get to working that crazy idea that they had on the drive to the office. So it's just been neat to see these very human, answers as it relates to how we can help them do their job a little better.
Yeah, no, I think it's a really kind of interesting perspective on it. And Jake, believe it or not, we're already almost out of time. So I'm going to ask a final question, which is, kind of based off of the experiences that you've seen, what do you think is going to be the next area that you see the opportunity and that you're going to be looking to tackle?
I think for us, one of the things we're wrestling with health systems is how to adjust the user experience for the staff so that they can drive better outcomes through the referral process. And the natural jump is like, oh, we just put agents in there and it's going to automate all these things. And I don't actually think that that's right, or at least I think that that's incomplete. I think that agents will have an important role to play in the future of healthcare operations. But in real life and working with real referral leaders and process leaders and things like that, that's probably the next thing we're going to look at is in what specific ways can we use our agent technologies and visibility to automate quickly and help prioritize, but what are those important human in the loop areas within the referral process where we shouldn't hand that off to an agent or some other automated technologies. And so I think we've developed the kind of AI native solutions to be able to see it. So now as we move into the management layer of how do we actually want to change the user experience, those are the areas that we're looking at is where do we want to help these humans do their job better, and how do we apply these technologies to be able to do that. And we're starting in the referral space as it relates to that.
Yeah, no, certainly be a development to keep an eye on. But as I said, believe it or not, we're already out of time. I want to thank my guest, Jake McCarley, for a great conversation today.
Yeah, thanks for having me.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.